Welcome to today's lesson. We're going to take a look at bipolar disorders and how they're organized in the DSM-5 TR. So first of all, these have been separated from the category that they were in the DSM-4 TR. Before they were in the depressive disorders, we now have a whole new category just for bipolar disorders. In this category, the primary criteria for manic and hypomanic episodes, criteria A, will now include the emphasis on changes in activity and energy. Previously, we were looking just for the mood. Now we're looking for the activity and energy levels, which might be very different. A manic episode will be characterized by extreme happiness or extreme irritability. We'll also see a lot of hyperactivity, very little need for sleep, racing thoughts, and sometimes that will lead to rapid speech. When people are not in the manic episode, we'll see the depressive episode, and that will be characterized by extreme sadness, a lack of energy or interest in activities, and an inability to enjoy things that are usually pleasurable. There also tends to be a lot of emotions such as helplessness and hopelessness. On the average, someone who has bipolar disorder might have up to 3 years of normal mood between those episodes of mania and depression. So we're not necessarily flipping back and forth between only mania and depression. We also have some time periods where the mood might be normal and seem very stable. In this category, we have 3 primary things we're going to take a look at. We're going to look at bipolar 1, bipolar 2, and cyclothymic disorder. I always think it's interesting to look at the etiology or why different diagnoses take place. But unfortunately, we usually don't know, and that is also true for bipolar disorders. There's no single cause, we do know that much. Indeed, like all psychological disorders, bipolar is a complex condition that has multiple contributing factors. So typically, we're going to be seeing 3 different things combining. We're going to be looking at genetic factors. Bipolar disorder does tend to run in families, so researchers believe there may be a genetic predisposition for this disorder. Scientists are also exploring the presence of abnormalities on specific genes. So in the future, we might be able to do some testing of genes to see if bipolar disorder is a part of a person's makeup. We also have some biological factors that might cause or contribute to causing a bipolar disorder. For example, researchers believe that some neurotransmitters, including serotonin and dopamine, are not functioning properly in people who have a diagnosis of bipolar disorder. And then that third piece is environmental. Outside factors such as stress or a major life event can trigger any genetic predisposition or biological disposition into that reaction. So if bipolar was only genetic, all identical twins would have the disorder or the diagnosis. But research is revealing that sometimes one twin will have the disorder and the other does not. So that says to us that the environment is a potential contributing cause, not the only cause, but a part of it. So if we're taking a look at bipolar 1, we can see this starting on page 139 in our DSM-5 TR. In this one, the main thing that we're looking for is that the person will meet the criteria for a manic episode. It has to be a full manic episode. However, that might be preceded or followed by the hypomanic episode. Could also be followed or preceded by a major depressive episode or that kind of neutral, stable time frame that we talked about earlier. The other thing that's really important to note for bipolar 1 only is that there can be psychotic features, not always, but it is possible, and that can also include grandiose delusions. So what we notice is that manic episodes often result in that marked impairment in social or occupational functioning, and it can actually require hospitalization to prevent harm for self or others. So when people are in a manic episode, first of all, they don't tend to think that they need any support or help in that time frame in the manic episode because they're feeling pretty good most of the time. They're typically happier, they have more energy, they feel like they're getting a lot done, even though they're not sleeping and not functioning fairly well. So they might think, oh, I don't need to go to work anymore because I am now the best trapeze artist in the entire world, so, or I will be as soon as I practice. So I'm just going to quit my job and I'm going to go and join the circus. Um, that's obviously going to get in the way of their occupational functioning. And that's the kind of thinking that we might see in a manic episode. So they're not probably going to be coming into treatment during that time period. They'll usually be coming in during a depressive episode because of that low mood and that hopelessness. So often you're not going to see people coming in the manic phase because they don't think they need treatment. Our overall prevalence is about 1.5, and we do tend to see this a little bit more in males. We also see that strong family component. So look at the family history if this is something you suspect. Schizophrenia and bipolar may share genetic origins, so that's also something to keep in mind when you're looking at family history. The other thing to really be concerned about is that suicide risk, again, mostly in that manic episode because people's judgment is severely impaired. So they might think, I can fly, like the trapeze artist maybe. Or maybe they think, I can fly, I'm going to go up to the top of a roof of a 20-story building and jump off so that I can fly around town. So the suicide is not always intentional. It's not always an action that's done with the goal of ending one's life, but those risky behaviors, that lack of judgment, that grandiose or other psychotic features can contribute to perhaps an unintentional suicide. Bipolar 2 is going to look quite different. It tends to be a little bit less severe, but still something that is going to need a fair amount of treatment. Instead of the manic episode, here we're going to have hypomanic episodes. So they're less intense and they tend to be somewhat shorter. Those again could be following current depressive episodes that could come before or after. We'll also see at least one major depressive episode of at least 2 weeks. And we're going to have that hypomanic episode lasting at least 4 days. Again, people tend to present to the therapist during the depressive episodes. Typically in hypomania, they're not going to be complaining about how they're feeling. Again, there's going to be some impulsivity that could contribute to those suicide attempts. That can also contribute to some substance use disorders. So that's another thing to look at if you're working with someone who has bipolar 1 or 2. The prevalence of bipolar 2 is a little bit lower. You're actually a little bit more likely to see bipolar 1 in your therapy office. And both of these will begin in more of that late adolescence or early adulthood time frame. The average age of onset is somewhere in the mid-20s. Cyclothymic disorder is the third one that you will see a fair amount, 159. For at least 2 years, numerous periods with hypomanic symptoms that do not meet the criteria for a hypomanic episode. So there's symptoms, but not enough to meet the full criteria, as well as numerous periods with depressive symptoms that do not meet criteria for a major depressive disorder. So here we're looking at that essential feature as a chronic fluctuating mood disturbance, but not enough or not following the right patterns to be diagnosed as bipolar 1 or 2. A little bit of a range for that prevalence. I think this is a little bit more of a mystery for a lot of clinicians. 0.4 to 2.5%, and a 15 to 50% risk that that person may develop bipolar 1 or 2 over time. So make sure you're always going back and checking in to see if your client's diagnoses have shifted. So Again, different types of bipolar. Bipolar 1 is considered the classic type. You must have both manic and depressive episodes, and there may be psychosis. Bipolar 2 has less severe hypomanic episodes, but the depressive episodes are very similar. Encyclothymia is that chronic but milder form of bipolar, characterized by episodes of hypomania and depression that can last for at least 2 years, but does not reach that threshold of the criteria for bipolar 2. You can see mixed episodes where mania and depression occur at the same time. So this is a very interesting version. I actually don't see this very much in my office, but it could happen where people might feel they have the emotions of hopelessness and depression. However, they have the energy and they have motivation to engage in those risky behaviors. So that's something to keep an eye on, that there might be a blending of those two kinds of episodes. And then we also have rapid cycling bipolar. This is for this is for individuals who will experience episodes 4 or more times a year. So we're switching back and forth between the mania, the depression, 4 or more times within 1 year. We're not having as long of a time period of that stable mood. So that's kind of a nice little summary to look at if you're not quite sure which one might be the correct diagnosis for the client at this point in time. Remember to always continue to go back to your DSM for the specific criteria, as well as continue to check in with your clients to see if this diagnosis is shifting, such as cyclothymia moving into maybe bipolar 2. Also continue to look for all of those comorbid diagnoses, because if you have someone who has one of these bipolar disorders, it's quite likely that they might also have other diagnoses as well that could include anxiety disorders, depressive disorders, other mood disorders, substance use disorders. Lots of different things could be happening at the same time. So that is our discussion on bipolar disorders, and we'll see you again next time.